I shall be talking about in today's presentation regarding management of cancer pain. I bring you greetings from India. I work in a place in a state of Uttar Pradesh, which is situated in the north of UP, India, which is also the land of Taj Mahal, that is Agra. Agra is very near my workplace, and it is around 200 kilometers from this place. And I work in a tertiary care hospital by the name of Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And this is the photograph of the building where I work. Today I shall be talking about management of cancer pain with emphasis on interventions. Talking on intervention and role of intervention in management of cancer pain, it in itself is an immense topic. It is a huge topic, and dealing with this subject in the limited time period, I feel like this cowboy who has been asked to tame a bull from Switzerland. However, I shall try my level best. Today, I shall be covering this topic under the following subheads. First of all, cancer pain, then when to go in for intervention in these patients, then what are the advantages of early intervention, then what are the modalities available with us, then something about neurolytic agents, various neurolytic blocks, and would also share with you our experience at SGPGI as regards to these blocks and procedures which we do. If you look at this slide, once the diagnosis of the cancer has been made through screening, then patient is bound to have pain because of the various procedural pains, could be because of the surgical procedures done on these patients, or patient could suffer pain because of the treatment related pains which this patient is being subjected to, or pain could be because of the metastatic disease, or pain could be because of the end of life care. At times this pain, there could be remissions in this pain, and then there could be relapses in this pain as well, till the time patient expires. So this cancer pain could be because of the procedures, because of the treatment related to procedures, because of the metastasis itself, and etc. and so on. Cancer pain, if you look, it is defined as called as total pain, and total pain has got various components, like the cause of the cancer pain could be physical, cause of the cancer pain could be emotional, it could be social, then there could be financial cause to the pain which the patient is suffering, then there could be spiritual cause as well. Why there are so many people, but why I am suffering from cancer, and thus the pain associated with it. And then another component of this cancer pain is psychological component. And all of these could be present at one time, or many of the components could be present in a patient at a given time. Then the treatment options for these patients are, these patients with the cancer pain could be put on pharmacological management, then they could receive radiotherapy for their management, then they are put on initially on opioids, or they could undergo surgery, then these patients need psychological support, and their other modality of treatment are adjuvants along with cancer, opioids and chemotherapy. So for the management of cancer pain, it has to be a multimodal approach and multi-pronged approach as well. Then you see that around 10 to 30% of the patients who fail to respond to oral therapy or medications respond favorably to interventions. That means, but intervention should not be considered as an adjuvant analgesic, not definitive pain relief treatment. So of all the options, intervention should also be taken as one of the modalities for the treatment of cancer pain. Now, coming to interventions, there could be two types of interventions. One, to begin with, one has to perform diagnostic block, which could be done with either with local anesthetics and with or without steroids. And once the response of the local anesthetic or the diagnostic block is response to the diagnostic block is seen, then subsequently one could plan for therapeutic or so-called permanent, though it is not permanent, but at times when people call it as permanent, and these options could be, we could perform chemical neurolysis in these patients, or one could cause cryoablation, then radiofrequency lesioning of the nerves causing pain, or there could be neurosurgical procedures could be done in these patients. And for assessment of pain, as you know, there is a scale known as visual analog scale, where marked from 0 to 10, where 0 is the minimal pain and or no pain, whereas 10 is the maximal possible pain which a patient could imagine. And on this the patient marks the intensity of pain which he or she might be suffering, and that is how we assess patient's pain. And this visual analog scale could be in English, could be any regional language, so that the compliance of the patient and patient understands this scale comprehensively, and thus patient is able to respond to the scale and provide answers so that we can assess patient's pain. Now, moving on to interventional procedures, they could be of various types, could be autonomic nervous system blocks, could be neuroaxial blocks, could be peripheral nerve blocks. And in the autonomic nervous system blocks, there are Gasserian ganglion block, one could perform striate ganglion block, one could perform celiac plexus block, one could perform lumbar sympathetic block, superior hypogastric plexus block, and ganglion impar. Whereas in the neurolytic axial blocks could be either by chemical neurolysis or by administration of opioids at that particular site. Moving to peripheral nerve blocks, C2, C3 nerve blocks could be done. Similarly, glossopharyngeal nerve blocks are being done. Then one could do trigeminal nerve block, and one could even perform intercostal nerve blocks. And how to increase our success rate? For that we need interventional aids, and these could be nerve stimulator, then one could use fluoroscopy, then one uses ultrasound and CT scan as well, depending on the availability and the expertise of the performer. At times one could even use two of these interventional aids, like one could simultaneously use a nerve stimulator with ultrasound. Now, moving to selection of patients. One needs to balance between indications and contraindications. Moving to indications, intervention should, this is not a rule of thumb, there are not very clear guidelines on this, but major indications are for intervention are when the life expectancy is more than 3 months, and when these patients are either opioid intolerant or because of the non-availability of opioids. And one of the most important indication would be availability of expertise and infrastructure for giving these interventions. Contraindications would be life expectancy less than 3 months. This could change. This is not fixed, depending on the, again, availability and expertise. Then the general condition of the patient. If the general condition of the patient is poor, these patients might not tolerate the intervention. So it's better not to do intervention in these patients. Then in patients with history of bleeding disorders, it is better to avoid doing intervention in these patients at that particular stage. And the success of intervention would again depend on the expertise of the person who is performing and on the availability of aids for the giving intervention like fluoroscope, CT, ultrasound. And prior to performing any blocks, it is permanent blocks, it is advisable to perform a diagnostic block and look for the response of the diagnostic block. And if the diagnostic block is successful, then only one should go in for therapeutic blocks. Moving to selection of patient. Proper history and examination is of utmost importance. We must know the disease status of the patient, his diagnosis, treatment, what they are taking, local recurrence, metastasis if any, what is the, as I was talking, in the indication and contraindication, life expectancy of the patient, what is the general condition of the patient, age, nutritional status, then what is the patient's performance scale, and other concomitant treatment which the patient is receiving at that point of time. Then in the moving to assessment of the pain, assessment of the pain is done by visual analog scale. We need to know type of pain, whether it is visceral, neuropathic or mixed, severity and duration of the pain. Then again a very important thing is we must know about the pregnancy of the patient, because majority of these interventions at various centers are done under CRPS, and thus we are exposing our patients to radiation. And in case of pregnancy, if we come to know that the patient is pregnant, it's better not to use CRPS and use other aids to facilitate intervention. Then in majority of these blocks are performed in prone position, as you see. And if these blocks are to be done under prone position, we must ensure that patient is able to lie in prone position. Many times if the patient is having ascites, severe ascites, mainly in cases of hepatobiliary malignancies or intra-abdominal malignancies, there are a lot of ascites there. And if patient is already decompensated, he or she is unable to breathe properly. And if you put this patient in prone position with lot of ascites, patient won't be able to lie down for the desired time, like maybe minimal 10 to 15 minutes as well. So it's better not to plan a surgery intervention in these patients in prone position and opt for a technique which could be done in supine position. And before moving to the performing of the procedure, one needs to take an informed consent from the patient. There should be proper counseling of the caregivers and the patient as well, and they should be explained about the procedures which we are going to do and complications associated with the procedure, along with the financial aspect of doing the procedure. And once the intervention has been done, one must remember, if the intervention has been successful, then there will be decreased pain of the patient, and this should mean that we need to taper his analgesics. If suppose patient was on narcotic analgesics, opioids, then following the procedure, patient would need less doses of opioids for suppression of his pain. And if we forget to do that, then patient might land up into respiratory depression. So this is very important to remember. As we know that for prescription of analgesics, there is a ladder. WHO has come in year 1986, it came out with the first edition of WHO ladder. And the one which I am showing right now, then it was subsequently modified in the year 1990, and then again it was modified in the year 1996. The one which I am showing today, it is of the one which was modified in the year 1990. So this is the second version of the WHO ladder for intervention of analgesic ladder actually. So it has got 3 steps, as you see: step 1, step 2 and step 3. At step 1, when the patient has mild pain, they have to be put on non-opioids with or without adjuvant analgesics. If pain is mild to moderate pain patient is suffering, then because in the older ladder, that is of the 1986 ladder, the weak opioids have to be administered, and then they could be given with or without adjuvants or non-opioids. And in the step 3, the strong opioids with moderate to severe pain plus non-opioids and adjuvants plus minus. So in the 1990, they modified it to, it has been modified that here from weak and strong opioids, they have come out to opioids in both the situations. And in the 1996, it has been modified that, as you see in the 1990, that non-opioids have to be given. Now the latest modification of WHO ladder, and they have said that non-opioids may or may not be given. So that means for management of pain, there are 3 steps: mild pain, mild to moderate pain, and severe pain. And depending upon that severity of the pain, analgesics have to be increased, or from one analgesic, one has to move to a different analgesic. So, as an interventionist, the first question which will come to my mind is, when should an intervention be done in these patients? Do I need to exhaust all these ladders and the intervention has to be done at step 4, or could I do my intervention at the stage 1 only? Subsequently, again WHO came out and said that intervention or invasive procedures could be taken up as step 4 on the ladder. So step 4 of the ladder. So that means by this I have to wait again to exhaust my 1, 2, 3 steps, and then only I could give intervention. But subsequently again they came out with a clarification that intervention is a 4th ladder, but it could be possible at any step. One could go do it is actually like an umbrella, and it, depending on the need of the patient and the expertise of the performer, it could be given at any step. Could be at step 1, could be at step 2, or could be at step 3, or could be at step 4. And they even said if one could give it earlier, it is even better. So that means there has to be some advantages of early intervention. The advantages of early intervention would be, number 1, that the anatomy malignancy is not very large, malignant tumor is not there, anatomy of that structure is well maintained. Thereby, performing the intervention block in these procedures, in these patients, if we go in for early intervention, would be easier. And thus the success rate and the response would be better. That would be number 1 advantage of giving an early intervention. Another advantage of giving early intervention would be that suppose the patient was at the 3rd stage of the ladder, we perform intervention, patient's pain subsides. So now the patient analgesics requirement will go down, and he might be now this patient could be treated as a step 1 patient for analgesia, for the management of analgesics in this patient. So the requirement of analgesics will go down, and thereby the quality of life of the patient is improved. So these are the 2 major advantages of early intervention. Moving to efficacy of interventions. In a study by Wong et al., they reported that there was a greater decrease in pain intensity with neurolytic celiac plexus block as compared to systemic analgesics. So they found that neurolytic blocks were better as they cause much more decrease in pain as compared to systemic analgesics. Similarly, Oliveira et al. Observed that neurolytic sympathetic celiac plexus block, superior hypogastric block, and lumbar sympathetic block decreased opioid consumption as well as improve the quality of life. So I think we are sufficiently convinced at this point of time that given the expertise and availability of infrastructure, intervention should be done early, as it decreases the doses of the analgesics and as well as it causes increased in the quality of life of the patients. Now, moving to what are the other options available with us for management of pain. One could be continuous subcutaneous infusion of opioids. It was in vogue in the earlier days, but with the advent of, and they were effective as well, but with the advent of newer techniques, drugs, cannulas, which could be left into the vein for longer period of times, and availability of patient-controlled analgesia and infusion systems, now continuous subcutaneous infusion of opioids is not done on regular basis. Then, intravenous infusion of opiates with patient-controlled analgesia. This is another modality of managing pain of these patients. But when do we need this actually? This is intravenous infusion of opiates when either the patient is unable to take analgesics, medications by oral, could be suffering from vomiting, diarrhea or paralytic ileus, or when there is a need to titrate patient's analgesics at a very short interval of time. Patient doesn't give us that much of time, is suffering from severe pain, then we could give them intravenous infusion of opiates, and subsequently these patients could be connected to patient-controlled analgesia. Now, many a times we come across patients who on themselves, either they are illiterate, they don't want to use PCA, or they are not in a condition to use patient-controlled analgesia. Then in those situations, it could be given to the attendant of the patients or the staff nurses, or even the staff nurse and the attendant of the patient, who could press the patient-controlled analgesia button, and thereby patient can take the medication. The medication reaches to the patient, and thus patient is pain-free. Intraspinal analgesia is another modality of administering analgesic to the patients. Here the principle is that the opioids are administered in close proximity to substantia gelatinosa, and thus very low doses of analgesics are required, and thus very minimal side effects. And the biggest advantage of this technique is that there are multiple agents for multiple types of pain. Suppose the pain could be neuropathic, somatic and visceral. Depending on the type of the pain, we could choose the analgesic and thus manage the patient suffering. Then, intraspinal analgesia could be either given spinal or via epidural route. Depends. If the expectancy is of more than 3 months, then one should go in for intrathecal therapy with subcutaneous implanted pumps. Whereas if the expectancy is less than 3 months, then epidural therapy should be instituted, and this should be connected to patient-controlled analgesia. Clinical pearls as regarding intraspinal analgesia are: place the tip of the catheter in the dermatome corresponding with the area of pain. Then, for somatic pain, one has to administer local anesthetic with opioids. For neuropathic pain, clonidine with opioids does wonders. Then, as we know that cancer pain, at times it metastasizes into the very common site of metastasis from prostate, breast, into the vertebral column. And the reason for that is that the veins of the vertebral column do not have walls, and thereby whenever there is increase in abdominal pressure, secondaries migrate to the vertebral body, and therefore they present as severe pain into the vertebral column. And in these situations, if we do vertebroplasty in these patients, patient becomes, it is an invasive procedure definitely, but whatever you do in these patients for vertebral fracture, vertebral metastasis, pain is very tremendous, very high degree of pain is there. And if you perform vertebroplasty in these patients, patient is able to move about and his pain is taken care of immediately within couple of hours. So vertebroplasty has a role in the management of vertebral secondaries. Another modality is spinal cord stimulation. It has got role in cases of postsurgical pain syndromes, or in cases of chemotherapy-induced peripheral neuropathy, or in cases of post-radiation nerve injury. But in the patient selection, it is an expensive modality, number one, needs expertise, and one also needs to take into account that in cases if the patient needs subsequent MRI, then MRI would not be possible in these patients where spinal cord stimulator has been placed, and thus assessing the progress of the disease becomes at times difficult. So patients should be put on spinal cord stimulation only when other modalities are not working or not helping to the patient. Neuroablative surgical techniques, they were in vogue in the earlier days, but with the advent of newer techniques, newer methodologies, newer aids, these are fallen out of favor. And like pituitary ablation, however, it is done at times in cases of hormone-dependent tumors of breast and prostate. Similarly, cordotomies has a role in cases of lesions where the lesion of the spinal cord is made to relieve unilateral truncal or lower limb pain. Now, moving to neurolytic procedures. Indications are severe, intractable, persisting pain even after less invasive techniques. So, less invasive techniques have been done, but the pain is still persisting. Or there are intolerable side effects to analgesic therapy. Patient is not tolerating the analgesic therapy. Or intrathecal pump has been ruled out because of the cost, because of the non-availability. There is advanced or terminal malignancy. Pain is localized and relieved by diagnostic block. We have given a diagnostic block and the response to diagnostic block is good. So this is a patient for neurolytic block. There are no undesirable side effects with local anesthetics, and patient and his family have got realistic expectation. So this is a proper candidate for neurolytic block. Limitations, but before giving neurolytic block, one should know that it has got its own limitation. Like, one must know and tell the patient that the quality of analgesia is less than that of local anesthetic block. So that would be one point which patient needs to know. Then again, at times it is called as permanent block. Permanent lesion made and the permanent block is there. But it is not true. Duration of analgesia is limited and it is not permanent. Then if you do neurolytic block, as I was talking earlier, you need to regulate his analgesic medication. It needs time, patient's time, attendant's time, as well as physician's time and expertise. And the procedure could be associated with complications, long-term complications also, like weakness of function, ambulation, numbness, neuropathic pain, dysesthesia, skin ulceration, etc. And at times the block might fail as well. So these are the limitations of the neurolytic block, which should be shared with the attendant and the patient as well. There are two types of neurolytic agents available. One is alcohol, commonly used, another is phenol. Advantages with the alcohol is it is readily available in the market, used in a concentration of 33 to 100%. Regeneration is delayed, and thus the sensation might come back after 3 to 6 months, but for 3 to 6 months patient could be pain free. Another advantage with alcohol is that, as you know, it is hypobaric in relation to CSF. So what happens? That means if we have to give alcohol, the painful side has to be, if we are planning to give alcohol in the subarachnoid space, then the painful side has to be up. Thus the patient can lie down the table on the non-painful side with the disease side up. So that is a major advantage of alcohol being hypobaric. Whereas if you plan to give phenol in this patient, it is hypobaric. So the diseased or the painful site has to be low down. So patient has to lie on the side which is painful. Then with phenol it has to be prepared. It has to be made before injection, and it has got a shorter duration, like from 2 months to 4 months. And another disadvantage with phenol is it is more destructive to vascular structures than the neural structures. Another important point at this point would be to know where location of sympathetic blocks. But because for pain relieving, for neurolytic blocks, many a times we perform sympathetic blocks. So we need to know the position of the sympathetic ganglions, various ganglions, and all the time we have been told the location we have been studying, and most of the times we forget in the exams as well, where is the stellate ganglion situated, where is the celiac plexus situated, where is the superior hypogastric plexus situated, where is the ganglion impar situated. So here I would like to share with you that a rule of thumb which is very easy to remember is that suppose we talk of stellate ganglion block, of stellate ganglion. Of all these major ganglions are situated at the junction of one part of the, like cervicothoracic junction. So stellate ganglion is situated at the junction of cervical with the thoracic. That means in front of, basically in front of the C7 and thoracic 1. So at the junction of C7T1. Similarly, now if I ask where is the celiac plexus located, then celiac plexus is located at the junction of thorax with the lumbar. So it has to be in front of T12 and L1. Similarly, now if I talk about the superior hypogastric plexus block, it is situated at the junction of lumbar with the sacrum. So at the junction of L5S1. So in front of the disc between L5 and S1. Similarly, ganglion impar is situated at the junction of sacrum with the coccyx. So this is how it's become so simple to remember the location of sympathetic ganglions. Then various autonomic nerve blocks, neurolytic blocks. Suppose the stellate ganglion is done in cases of head pain or limb pain, upper limb pain. Basarian ganglion block in cases of trigeminal neuralgia or facial pain. Celiac plexus block in cases of pancreatitis, abdominal pain, visceral cancer pain, etc. Lumbar sympathetic in cases of lower limb pain. Hypogastric plexus block for perineal, pelvic and lower limb pain. Whereas ganglion impar in cases of perineal pain or rectal pain. So just to touch upon celiac plexus, indications are cancer, stomach, pancreas, gallbladder, liver, duodenum, bile duct, acute pancreatitis and chronic pancreatitis as well. And complications with it is done with, could be done with 100% alcohol or 50 to 100% alcohol. Various techniques: posterior approach, transaortic approach, endoscopic. For suppose the patient is suffering from ascites, cannot lie prone, it's better to do celiac plexus block with ultrasound guided celiac plexus block, which would be done from the anterior side of the patient, abdomen. The other approaches for the patient has to lie prone. The conventional teaching is like patient lies prone, classical approach, 7 centimeters from the midline, at the lower border of T12. You make a mark out here and direct your needle towards the junction of T12L1. This way. And if you will see on the C-arm, then your needle will be on the, and the lateral will be on the anterior side of the junction of, this is T12, this is L1. So somewhere here, put in the dye, you'll see a linear spread of the dye. This, and most of the times it is advisable to give bilateral blocks because that causes a response of the treatment is better. And if you will see on the AP view, then you will find that the spread of the dye is in front of the vertebral bodies. Then Essenberg performed a meta-analysis where 24 studies were performed as regards to celiac plexus, and they found that the 89% had a good to excellent results beyond 3 months, with side effects, and that too which were very transient. Similarly, stellate ganglion block, it is performed in cases of post-mastectomy pain, phantom limb pain, vascular pain in the upper limb, or CRPS. And the disadvantages with this could be Horner syndrome, and the complications associated are intravascular injection into the vertebral artery, recurrent laryngeal nerve block, or phrenic nerve block. Moving to superior hypogastric plexus block, it is technically more difficult. As I was talking, all these sympathetic blocks have to be given bilaterally because they are they are on the two sides, and here one has to enter between at the junction of L5 and S1. So this is how the needle has to go. And there was a study done by De Leon who included 26 patients of gynae, colorectal and GI cancers, and they did bilateral superior hypogastric block with 8 ml of phenol on both sides, and they found that the dosage requirement of morphine was reduced, and there was marked improvement of VAS. Pain reduced came down to 4, and there was a good response up to 6 months of follow-up. As you can see here, the sympathetic chain of the both sides merges at the junction of sacrum with the coccyx, and that is known as ganglion impar. And so for ganglion impar, one has to give one intervention only, and one has to block from one side only. And the indications are visceral pain or sympathetically mediated pain of the perineum and lower pelvic area, which could be because of secondaries in the pelvis, because of arising from the rectum, uterus, or prostate. Patient lies prone, needle is passed. This is here the needle goes. One has to be careful that the rectum is there, so one should not go inside much. If you go deep, then one could injure the rectum. And after giving the dye, if you see, this is the position of the rectum, this is how you go, and this is the spread of the dye. I'll leave this. So why one should replace subarachnoid or epidural neurolysis by celiac plexus blocks, superior hypogastric plexus blocks, or lumbar plexus blocks? Because they are highly specific, and thus there is less risk of bladder and bowel and lower limb or lower extremity paralysis. And this is our experience as regarding to various intervention procedures since we started these in the year 2009. Until date, we have done 20 stellate ganglions, celiac plexus 106, lumbar sympathetic 36, superior hypogastric 16, ganglion impar 33, Gaussian ganglion blocks 18, glossopharyngeal nerve block 16, lesser and greater occipital nerve block 3 cases. We have done 8 vertebroplasties and 1 kyphoplasty. So to conclude, interventions are not to be used as last modality. They are helpful, greatly helpful in enhancing the quality of life of patients and decreasing their pain and consumption of analgesics. And following intervention was must remember to decrease the doses of opioids. Here you can see this patient, this person, he doesn't have a limb, but he thought that he's a father of this child, and his child was asking, "Father, I want to learn cycling." And this father decided, despite his inability, he decided that I would teach my son how to cycle. And so he is able to do that. So once we decide that we are going to do something and we are convinced, we can do it. And this is what, never say that we can't do anything for this patient at this condition, but because if you think and decide to help the patient, something or the other will come up by which we can help the patient suffering, minimize patient suffering. Thank you so much.